iliac. And if you guys can't read my handwriting, please let me know. I have like horrendous handwriting, and this pad that I'm using is awful. So, but the inferior epigastric artery anastomosis with the, and I'm going to do a little at sign with the superior epigastric. Yeah, that's coming back. So that superior epigastric artery comes from, as we know, the internal thoracic artery in the chest. It runs on either side of the sternum, and it travels basically through the diaphragm into that rectus abdominis muscle and anastomoses to the inferior epigastric, and that's going to do like all the blood supply for your abdominal muscles. The deep circumflex scapular anastomoses with another artery that we've talked about, and that's the musculophrenic artery. Okay, so we know that that internal thoracic artery is going to give off both of these. The one that's going lateral is the musculophrenic. That's going to supply the diaphragm, and then it's going to continue down and anastomose with that deep circumflex iliac. Okay, I'm only going to do it on the right side, or I guess this is the left side of the patient, but just know it's the exact same thing over here. So if we have time, I'll complete it. So that's the first thing that I want to talk about. And like I said, you probably spoke about this briefly today, maybe. But now we got to build our foundation. So remember, this whole thing here, this big red line in the middle, is the abdominal aorta. It's going to give off three. It gives off a lot more than three, but there's three main branches that, like trunks, if you will, that we care about. And that first one, which you guys will talk about early next week, you might even see it in lab this week, is the celiac trunk. Okay, this is at approximately the level of T12. So basically, that aorta, as it pierces the diaphragm at the level of T12, as soon as it goes through, it basically gives off the celiac trunk. Now, the celiac trunk is massive. It's very easily identifiable in lab. It basically, like I said, as soon as the aorta passes through at the level of T12, it's going to throw off the celiac trunk. And the celiac trunk is going to give off quite a few arteries that we're going to talk about in a second. I just want to talk about the other ones, and then we'll come back to this. But just to give you guys a general relationship, like the relationships, to give you like a sense of where we're at. Like I said, we're right below the diaphragm at the level of T12, and it's associated with the right next to the stomach where like the lesser sacral omentum is. So I know you guys, I think you guys talked about that today. I don't know, maybe you did, but just to plant these seeds early, we'll focus on the arteries. So that's at T12. We're going to go a little bit lower here. Now, this is not how it looks like in the body for sake of having like space where I'm putting it down here. But the next artery is the main big artery is the superior mesenteric artery. So I'm just going to write that as SMA, superior mesenteric artery. Now that's at the level of L1. So it's like literally right below the celiac trunk. So when you guys are in lab and you're dissecting, you don't have to go far below the celiac trunk to find the SMA. It's usually caught up in the mesentery, hence the name superior mesenteric artery. It's usually it's right underneath the pancreas, and it's caught up in the mesentery. You literally have to dissect out the mesentery to find it, but it's literally right below the celiac trunk. And then finally, the last main big branch, if you will, before we start going into the little nitty gritty, and I'm color coordinating this on purpose because there's a lot going on, is the inferior mesenteric artery, or IMA. Okay. And that's at the level of L3. So that one you do have to go a little bit lower to find. But you can see, I mean, this is a very tight space in the abdomen. These guys are not very far apart. So making sure, just checking the thing, you guys are still able to hear me. Everyone's good.
Yeah, we can hear you.
Okay. I can't see the chat, so I just want to make sure that everyone can still hear me. All right. So now we're going to zoom in on this celiac trunk. Now, I just want to let you guys know there are some branches that come off. There's a branch here that comes off. There's a branch here that comes off. you guys know about the renal arteries. The renal arteries come off. I will talk about that, but I just want to do these guys first. Okay. So we're going to go back to the celiac trunk. Now, there's a lot going on with the celiac trunk, but there's three that come off the celiac trunk right away, and they're very easy to identify because they're named where they're going. So the two that are going off towards the left-hand side, like I said, very conveniently named. Let me just draw it like this. You have the left gastric artery. So again, it's going to the left and gastric, so it's going to the stomach. And then you have the splenic artery. I think we all know where the splenic artery is going. Okay. So the left gastric artery is going to be on the lesser curvature of the stomach. Okay. So it's on that, if this is your stomach like this, that's a horrible drawing of the stomach, but this is the lesser side, that's the greater side. Okay. The left gastric artery is also going towards the esophagus. So if this is your esophagus and then you have your stomach like that, it's kind of flowing on up here in this area. And that's important because the left gastric artery gives off the esophageal artery. And again, very conveniently named. Guess where that's going? So this is your left gastric artery. It's kind of in this area, and then it throws off an esophageal one. So that's kind of nice. The splenic artery obviously is going to the spleen, and this is so identifiable, like on the lab. If you're confused whether or not you're looking at the left gastric and splenic, they kind of run right next to each other. But like pretty much every year, my master's year, first year, and I bet you this year, the splenic artery is very tortuous. It literally like twists around as it goes to the spleen. And it's usually much bigger than the left gastric. So when you guys are looking at lab this week, just trying to figure out what can I do tortuous and going towards the spleen. But the splenic artery is going to give off some branches. Okay, so it gives off quite a few. So this one up here is called the short gastric artery. Okay, it gives off another important one down here called the left gastromental artery. Okay, and I'm going to abbreviate this because we're going to come back to this, to LGO. Okay, that doesn't look like an L, but LGO. And then it also, to give you a sense of where we're at, this is the midline, right? We're right where the celiac trunk comes off the aorta. That's on the vertebral bodies, and then we're going towards the left. But the pancreas kind of sits like right here. Remember I said you have to kind of move the pancreas out of the way to see the celiac trunk in the SMA, because the pancreas is kind of in this area. So this guy is going to give off multiple arteries that are the pancreatic branches. Those you probably won't see in lab, but if you get a test question that's like, oh, the patient has, I'm trying to think of a common question, but basically they have like pancreatic cancer or something like that, and the cancer is growing and it's obstructing the branches that innervate the pancreas or supply the pancreas. Where are those branches coming from? Well, they're coming from the splenic, which comes from the celiac trunk. So left gastromental, that is on the greater curvature. Okay. And this anastomose with an artery that we're going to talk about in a second. The left gastric, like we said, is on the lesser curvature. That anastomose with another artery that we're going to talk about in a second. And the short gastric is also on the lesser curvature. So just to reiterate, you have your esophagus, and then you have your stomach coming down like that. This artery here, the left gastric, kind of wraps around and comes like this. Okay. And then you have the left gastric on the top over here. So, all right, LGO. So that's it for the first two branches of the celiac trunk. We're going to go to the right side now. So the right side of the body, or in the right upper quadrant of the abdomen, I know you guys talked about the quadrants, but the right upper quadrant, you're primarily concerned with the liver and the gallbladder. So all of the arteries that are coming off here are likely going to be, they're not likely, they are going to be supplying those two organs. Okay. So this branch, the final branch that comes off of the celiac trunk, the third one that they're going to ask you, is the common hepatic. That's kind of conveniently named because hepatic means liver. So you know it's going towards the liver. If it's a common, that usually means that there's going to be other branches coming off of it that are related to the liver. So we're going to talk about those right now. I just want to rewrite that. So the common hepatic is annoying because for whatever reason, it gives off the proper hepatic. And it's very hard to tell like what you're looking at in lab. Is it still common hepatic? Is it proper hepatic? That's going to take some time to get used to, and a lot of time in lab. I still have trouble identifying that. But the proper hepatic is going to give off two: left hepatic, and guess what? The right hepatic. And these are conveniently named. One's going to the left side of the liver, one's going to the right side of the liver. Very easy to identify in lab. Now, the liver is going to have the gallbladder kind of nuzzled underneath. Like if this is the liver like this, the gallbladder kind of is nuzzled underneath the side of the liver. So the right hepatic is going to give off the cystic artery, and that goes to the gallbladder. And that one's also very easy to identify in lab. This is where things get a little frustrating because there's a lot of anastomoses going on in this area. So the proper hepatic artery is going to give off an artery called the gastroduodenal. Now, that is pretty conveniently named because it's going to the duodenum, and it's also going to give off branches that go to the stomach. Because remember, gastro or gastric means stomach, duodenal means it's going to the duodenum. So this artery here is going to give off branches that supply part of the duodenum and part of the stomach. Okay, so you're going to have the right gastroomental. Because remember, we had a left coming off on the other side. And you probably guessed it, this right gastroomental is going to come, I'm going to do dots over here, anastomose with this left gastroomental at the greater curvature. So I drew it like this just so you could see the relationship. Normally on my line diagrams, I would just do like a little thing like that and do left gastroomental just for sake of space. But just so you know, this is kind of crossing over to the side to go to that greater curvature of the stomach. They're going to kind of meet, and if you guys were to pull up the pictures for your class slides, they kind of meet like right at the bottom of the stomach. So like the right gastroomental comes in like that from that gastroduodenal. Okay. Then you're going to have an artery that is it's variable where it comes from. Okay. It's the most annoying artery because in every single body, it's going to come off from someplace different. I'm drawing it from gastroduodenal just for the sake of the line diagram, but just know it has been, even in your lectures, I think I talked about this, that it comes off like common hepatic, comes off proper hepatic, comes off gastroduodenal, comes off right gastroomental. Just for the sake of the line diagram, though, I'm drawing it off of the gastroduodenal, and that is the right gastric artery. And again, if we had a left gastric, or if we have a right, we have a left. So left gastric on that lesser curvature over here, this is going to anastomose with the left gastric artery. And I'm just going to do it like this for sake of time. Left gastric at the lesser curvature of the stomach. And then finally, there's one more called the superior pancreatic duodenal. So this is, again, these are all very conveniently named. It's on the superior aspect of the duodenum and the pancreas. Okay. So that means it's going to give off blood vessels that supply those two organs. Now, if there's a superior, that means there's an inferior, and we're going to get to that in a second. So does anyone have any questions on the celiac trunk? If not, we can keep it moving. We're making good time here. So we're going to talk about the SMA now, the superior mesenteric artery. Like I said, that superior mesenteric artery is at L1. It sits right underneath that celiac trunk. You kind of have to move the pancreas out of the way, move the duodenum out of the way, and then you're going to kind of pierce away all of the mesentery to actually see it. It does have a very close relationship with the renal artery and the renal vein. So I don't know if you, this might be too early, but I don't know if you guys have heard of something called Nutcracker syndrome. Maybe, maybe not. But I'll talk about it because that's definitely going to be a test question, but we'll get to that in a second. So the SMA is much easier than the celiac trunk. There's only a few branches, and they're also very conveniently named. So I'm going to draw it like this, more so just for sake of like having like enough room. Um, but this is also kind of a pretty good representation of where things are at. Okay. So there's only a few branches, like I said, and they're very conveniently named. So the terminal one, the one that's all the way here at the bottom, why is my thing not zooming in? There we go, is the ileocolic artery. So that's right at the cecum where like the small intestine meets the large intestine. So ileo means ileum, and then colic means colon. So it's right where the ileum and where the ileum and the colon meet, which is called the cecum. Again, very conveniently named. And I'm also drawing it on the right side because that ileocecal junction, the cecum, is on the right lower quadrant of the abdomen. There's another structure that is you're definitely going to see this in your career probably hundreds of times that is inflamed and requires surgery to be removed, and that's the appendix in the right lower quadrant. So you have an artery that's named for going to the appendix. So we're in that right lower quadrant at that cecum. The appendix kind of comes right off from the cecum right there, so it's going to throw off an artery to go supply it. Now we just have to worry about the colon. So we have the right colic. I'm going to come back to that in a second. We have the middle colic. And then the last big one is the inferior pancreatic duodenum. So here's the one that anastomoses with the superior up here. Okay. So we're going to come back to, we're going to talk about this guy now, the right colic. So on the right side, you know, we're going back to, maybe you guys remember this from undergrad, you know, you have your intestines here, and then it comes into the cecum, and then you have the ascending colon, transverse colon, and then you have descending, sigmoid, and then the rectum. Okay, so the right colic is going to the right side of the colon, so guess what it's supplying? The ascending colon. Okay, so that's the right colic. The middle colic is going to the part of the colon that's in the middle. That's the transverse colon. So what you're going to see in lab is you're going to see this. This is the SMA. You're going to see this coming off. You're going to see it giving a branch that goes over, and then there's going to be a bunch of branches that go like this. Okay? Those are all considered branches of the right colic. And then you're going to see the middle colic come up, and it's going to give off a bunch of branches that are all going to go to that transverse colon. All of these vessels anastomose with each other. Okay, so there's a big anastomosis in that mesentery. So the ascending colon is getting supplied by the right colic. The transverse is getting middle colic. We're going to talk about the descending in a second, but all of the arteries in this area are being anastomosed with each other. So for the sake of line diagram purposes, so that you can remember it, what I'm going to do is I'm going to put a little, this is what Rosenthal did when I was a master's student too, is I'm going to put like a little like hashtag or money or a sign like this. And that just means that if you see this next to each other, any artery that has this next to each other, that means they anastomose with each other. Two more branches, and I cannot reiterate how conveniently named they are. We have one that comes off slightly higher up, and then another that comes off slightly lower. And it's really multiple branches, but this is the ileo branches and the jejunal branches. So if you guys couldn't figure out where those are going, I'm sorry. And that's it for the SMA. And now we're going to talk about the inferior mesenteric artery. And this one is even simpler than the SMA. Okay. So it's going to give off a few branches. And remember what I was saying before, that these guys are primarily responsible for doing the colon. Well, we talked about ascending and we talked about transverse, so now we have to talk about the descending colon and the sigmoid colon and the rectum. So most of the arteries that supply those areas are coming from here. So we're going to draw it the same way, and it's on primarily the left-hand side, so that's why I'm drawing it going towards the left. And just to reiterate, the IMA is at L3. So the right colic went to the ascending, and that was on the right side. Now we're on the left side doing the descending, so we have the left colic. Then we have the sigmoidal. So again, very conveniently named. And then we have the superior rectal. So that obviously goes to the superior aspect of the rectum. It has two arteries that it anastomoses with, and those two arteries do not come from the IMA. They actually come from the internal iliacs. So you have the middle rectum or middle rectal, and then the inferior rectal. And then these come from the internal iliacs. And you will see both of these in the lab. So we just covered almost all the arteries in the abdomen pretty simply in less than 30 minutes. This is going to be a lot of questions on your exam. You're going to be able to see all of these in lab, and you're going to have to be able to identify them. There's a few other minor branches that come off the aorta directly that I want to talk about. And I'm going to put those in orange. They're not really associated with anything. So the first one, and this is actually the first branch coming off the aorta, is before it makes the celiac trunk and right as it comes out of from underneath the diaphragm, you have one called the inferior phrenic. So remember, we had the musculophrenic that does the outside of the diaphragm. We have the phrenic nerve that innervates the diaphragm. So this just means that it's directly below the diaphragm and it's likely supplying the diaphragm. Just before the SMA comes off, we have a guy above it, and I'm going to kind of draw it like this just so it doesn't get in the way of our SMA here. But that is called the medial suprarenal. So this is going to the adrenal glands, supra meaning above the kidney. Again, all of these are so nicely named. And then right below the SMA, on both sides, we have our renal arteries. So this is renal artery. Okay. They're going to give off the inferior suprarenal, and then they also give off segmental, and we'll stop at that point because the segmental arteries are going to branch even further and further until eventually they become the afferent arterial going into the kidney. But you guys will have fun with that in renal in a couple of weeks. So you might have been asking yourself, okay, we have an inferior suprarenal, medial suprarenal. Where's the superior? This one's really annoying, and I'm not going to draw it, but maybe I will do a dotted line. That inferior phrenic gives off the superior renal, superior suprarenal. So if you think about this, though, you guys haven't had endocrine yet. I don't know if you guys have talked about the adrenal glands. The adrenal glands are incredibly important. They for something for being like a little tiny organ that doesn't look like much. You can't even see them in the cadaver because they just look like fat, so you end up like removing them. But you have your kidney, right? And then on top, you have the adrenal glands. They secrete like epinephrine, they do norepinephrine, they do cortisol, they do androgens. So like, especially in females, it's important because you can get estrogen for the adrenal cortex. They do aldosterone. They're responsible for so much things that are going on in the body. It makes sense that they have all these arteries going to it because all these hormones need to be secreted into the bloodstream so that they can cause their effects systemically. And then lastly, or not lastly, second to last, in between the SMA and the IMA, we have our gonadals. So that means either ovarian or testicular. So those come directly from the aorta. So like I said, I'll put that in parentheses. Testes or ovarian artery. And you guys talked about this today a little bit today with the spermatocord and all that fun stuff. And we actually have a lot of time, so I can even go into that a little bit. I did not expect to go as fast as we did, so that's a good thing. And then lastly, the last ones that come off, again, very conveniently named. They're kind of above and interspersed around the IMA, and I'm just going to draw like this, are the lumbar arteries. So yeah, that's it. I know it looks like a mess just because of how I was writing it. Um, what I can do is if you guys didn't keep notes with this, or even if you did, I can send out. I have a line diagram with this like already made, nice and pretty. I can send that out to everyone so that they can see it, and it's color coordinated and has all this information there. But does anyone have any questions about the abdominal arteries?
Sorry, quick question. Do you mind repeating what you said about where you have like the superior rectal? Does the middle rectal and the inferior rectal, do they come off of that or the internal iliac?
They come from the internal iliac. They're not branches of superior rectal. So these guys here, I'm trying to erase it. Maybe I'll just put these in like a box like that so that you know they're coming from the internal iliacs. But they anastomose with the superior rectal, which comes from the IMA.
Thank you.
Sure.
Tyler, I had a quick question.
Sure.
Can you reiterate what you said about which arteries go to ascending versus transverse?
Sure. Yeah. So, the colon has, the really like the four main parts, right? So you have the ascending, transverse, descending, and then sigmoid. And then I guess you get a little bit of the rectum. And it looks like this. The right hand side, which is all this side here, is going to be arteries from the SMA. Okay. So the at this point here, this is where the ileum meets the colon. That's the cecum. You're going to have an artery going directly there. That's in the right lower quadrant. So you have ileocolic. So that's this guy. The ascending colon, that is all on the right side. So it's like right lower quadrant and then the right upper quadrant. So that artery that's going to supply the whole ascending colon, which is only on the right side of the abdomen, is going to be the right colic. Then transverse, which is in the middle, okay? It's in the middle of the colon, it's in the middle of the body. It goes from right upper quadrant to the epigastric area to the left upper quadrant. That's going to be done by the middle colic. So the SMA is sitting like right in this area right here. It's given off the ileocolic, the right colic, and then it's going to throw off a branch that goes up like that and goes to the middle colic. Then we have the IMA, so the descending colon, which is on the left side, so it's in the left upper quadrant and starts to go into the left lower quadrant. That's going to give off the left colic going up. Then it becomes a sigmoid because the colon itself, we have the transverse, then we have the descending, it kind of makes this little S shape. That's where it becomes the S shape. That's called the sigmoid colon. So we have arteries named for being at the sigmoid colon. So they go like right there. And then the top part of the rectum, which is like this area right here, is the superior rectal. And that kind of makes sense why we have arteries, the middle and inferior rectal, coming from the internal iliac, because you guys will cover this probably in, maybe you'll do this for GI, but repro, in the pelvis, the rectum is actually like in the pelvis itself. It has like a direct relationship with the uterus in females. It has a direct relationship, obviously, with the prostate in males. And those arteries that supply those organs come from the iliacs. So it makes sense that those arteries that supply the middle and the inferior portion come from down here.
Thank you. I hope this is on your line diagram later.
This is on my line diagram. Any other questions about the arteries? And then I can do some stuff about what you guys covered in class today.
For the one that you said that is very variable, was that the gastroduodenal?
That was the right gastric.
So
So
how
this
would
guy
you
right here.
identify that if it's very like variable?
Like you mean in lab, how would you identify it?
Yeah.
So that's what's awesome about these arteries is they're all named where they're going. So if you trace an artery coming from, this side of the celiac trunk vessels, and you see it going to that lesser curvature of the stomach, more so on the right side, or you see it anastomosing with the left gastric up here on that lesser curvature, it's the right gastric. Does that make sense?
Yeah, thank you.
Sure. Any other questions?
Hi, Tyler. Thank you so much for doing this.
Sure.
I have a quick question regarding the lumbar arteries. So,
hmm
are they the ones that kind of like go along the spinal cord? Like, what is their main purpose?
Yeah, so those are going to contribute to arteries in the spinal cord. You're going to have arteries throughout the entire aorta that go towards the spinal cord. But the reason why these are particularly important is because they have some contributions to viscera as well as the muscles that sit in that area. So you guys will learn about this in like the posterior abdominal wall, but primarily they go to like the vertebral bodies and go to the spinal cord in the lumbar region.
Gotcha. Thank you so much.
Sure. I know this is really premature to talk about this now, especially because you guys haven't covered it in class, but unfortunately, they're not going to give you a line diagram. They're just going to like show you a bunch of pictures and talk about it. And I feel like having a line diagram definitely helps, especially if you do this early. And then when they start building on the layers and lecture, like this will be helpful in my opinion. But if you want, we got like 10 minutes left, I can talk about at least, I mean, I could do like the rectus abdominis and like go over how it transitions from like above to below the arcuate line, or I could talk about like the contents of the spermatic cord. I could talk about the borders of all of that. I have some pretty good mnemonics for it as well, for all three of those things.
Yes, please, Tyler. That would be amazing.
Okay, we can do that then. All right, so I guess I'll do the rectus sheath first, unless that's straightforward enough for everyone. Then I could just skip it. Okay, so we'll talk about it. So I'm going to say the mnemonic first, and then I'll draw like a little picture, and I'll show you what it means. So, like I said, this is talking about the rectus sheath and then the arcuate line. So my mnemonic is 2, 3, 3, 1. You're going to draw a little line between the 2 and the 3 and the 3, 1. This line is the arcuate line. So 2, 3, 3, 1. There's 2 things that are anterior. There's 3 things that are posterior above. So obviously this is above. This is below. And if this is confusing, I'm sorry. This is what helped me last year. And then same thing. There's 3 things that are anterior, 1 thing that are posterior below the arcuate line. And then you just have to remember that there's the superior epigastric above and then the inferior below. So those 2 things, you have E and I. You have I, T, T, and then it's the same thing, just E, I, T, and then just T. So those are referring to the muscles and the fascia at the arcuate line that make up like the rectus abdominis muscle, and then that like sheath. So the E, if this is confusing, I'll just stop. But this is how I did it, and it got me a lot of points on the exam. But the E is, sorry, this pad is so annoying. E is the external oblique. The I is the internal oblique. And then the two T's, one is the transversalis abdominis, or however you say it. And then the last T is the fascial layer. So the transversalis fascia, transverse abdominis muscle, sorry. So I'm going to like literally like draw this out. Sorry, my pad is not working. Oh my goodness. Okay, there we go. So you guys are probably all like, what is he talking about? So you have your rectus abdominis muscle like that. If we're above it, remember 2, 3, 3, 1. So above it, anteriorly, this is anterior, this is posterior. We're above the arcuate line. There's two things that run in front of it. So you have the external oblique and then the internal oblique. So let me show you guys the little thing here. Okay, so two things run anteriorly to the rectus abdominis muscle when you're superior, and then there's three things that are behind it. Internal oblique contributions, transverse abdominis, and then the transversalis fascia. Is this making sense to everyone, or am I just making it worse? That's not reassuring. So then below,
Sorry, I just had a quick question.
sure.
It makes sense, but I just wanted to confirm internal oblique is the one that kind of splits and runs both anterior and posterior to the rectus abdominis muscle. Is that right? It splits?
Right.
Okay.
Right.
Thank you.
Everyone good? And then I'll just do on the right side. So I'm going to draw a little like, so just for sake of time, this is above. And then this is what it looks like below. So that it's 3, 1. So then you have three things anterior. Okay, so that's external oblique, internal oblique, transverse abdominis, and then the only thing you have on the back is that transversalis fascia. You guys just had this today, so maybe it might be a little more, it'll make a little bit more sense, like once you've had some time to sit with it. But this is, I just literally like drew this out in the exam, and it got me a couple of points. Oh, what did I do? Okay, so now you guys are gonna think I'm nuts, but I have some ways to remember the spermatic cord and the structures that contribute to the inguinal canal. And that, to this day, is still like one of the most difficult things to remember. I'm going to try to do it as fast as I possibly can. So bear with me, because we only have a few minutes left. So the way I remember the contents of the like superficial inguinal ring and basically like what's in that spermatic cord in males is nice, but then I just add a D at the end, so niced. Okay. There's another inappropriate way that I can remember this, but I'm just going to leave it at that because this is run by the SGA. You can ask me later if you want to know what I have. But so the N for the superficial inguinal ring spermatic cord in males, the N is neurovasculature. Internal spermatic fascia. Cremasteric muscles. External spermatic fascia. And then D is ductus deferens. So one more thing, and then I'm going to draw a picture. This neurovasculature, there are specific things you have to know, unfortunately. So in the neurovasculature, you have the testicular artery, and then the pampiniform, whatever plexus, which is the venous system. And then there are two nerves, ilioinguinal and then the genital femoral nerve. And then just to talk about where these go to, this is doing sensation to the scrotum and the root of the penis. And then the genital femoral nerve is doing the cremasteric muscles. And also the cremasteric muscles also get some of the obturator nerve, but for right now, that's what we're going to talk about. So just to give you a quick drawing of this spermatocord, it's like a big circular structure, okay? On the outside, you're going to have that external fascia. So this is the external fascia. Okay. And of that, I wish I could do other colors, but I'm trying to get as much in as I can. Right underneath that is the cremasteric muscle. So I'll draw a little arrow. And then underneath that is the internal fascia. So if we go back to our mnemonic for a second, if you start from nice at the bottom of nice, this is going in the layers that you can see everything. So this is outside. So let me draw like over here. This is outside. This is inside. Okay. Then in the very center, so this is the exception. This thing that I'm drawing here, that's the ductus deferens. And then you just have like your testicular artery, the pimpiform plexus in here. So I'll just put arteries and veins. The last thing that kind of does its own little thing is in between the internal fascia cremasteric muscle right here. That's where you have the ilioinguinal nerve. So I hope this was helpful. I'm telling you, this got my points last year. Even we're doing renal and male repro for second year. So I've been getting like a lot of questions on the spermatocord and things like that. I've used this mnemonic like to this day to answer questions. In females, the main difference is that in this superficial inguinal ring, you're going to have the round ligament of the uterus, and that's it. That's the main difference. But for sake of time, I want to go over one more thing, and I'm going to do it quickly. So use your lecture notes from today because we got like 5-ish minutes left. So there's the structures that contribute to like the inguinal canal or whatever. So I didn't come up with this. I don't remember where I got it from, but the mnemonic that I had was malts. So M stands for muscles, A stands for aponeurosis, L stands for ligament, T stands for two things. It's the transversalis fascia and the conjoint tendon. And then S is the spermatocord content in males. So I'll just write for S. This is just the spermatocord, which is exactly what we just went over. So M is muscles, and this is like the superior aspect. So there's 3 muscles. External oblique, internal oblique, and then the transverse abdominis muscle. So the M, the muscles, that's literally like what makes up the rectus sheath and like at the arcuate line. So this is like the superior aspect of the inguinal canal, the borders. A is opnerosis. So there's two. It's opnerosis. I'm just going to write it twice just to keep our A pattern. It's the opnerosis of the external oblique and then the internal oblique. And I'm sorry about my handwriting. I promise you it's not that bad in like real life, but this pad is so annoying. And then A also has a third meaning. It's for the anterior border. So M superior, that's for muscles. There's three. A anterior is for opnerosis of the external internal oblique. L is for ligament. Okay, so there's two ligaments. The inguinal ligament, you guys all know where that is. Talked about that in MSK for a little bit. And then the lacunar ligament. So this L helps you for a number of reasons. You know it's for ligaments, you know it's the lacunar, but it also makes up the floor. And there's an L in floor. And then T, that's for the posterior aspect. There's two things. Okay, so there's the transversalis fascia. So again, that posterior aspect of the rectus abdominis muscle, that arcuate line, and then the conjoint tendon. And then this makes up the posterior aspect. So if you were to think about this like as a 3D structure, we've just hit all three of them. We have the top, it's made up of multiple muscles. Anteriorly, it's made up of the opnerosis of two of the muscles that are up here. So it's really like a box almost. It's like that. So the muscles are here. The opneroses for those muscles are there. The floor is the ligaments. So it's like kind of back like this. And the posterior aspect is back here. And that's the tendons. And if we remember from up here with the rectus abdominis muscle, and we have the 2, 3, 3, 1, well, the inguinal canal is going to be partly below. So there's going to be one thing here and then the three things there. This makes sense that it's on the posterior aspect because we're posterior to the rectus abdominis muscle. I hope that makes sense. I don't know. Maybe I'm just rambling up here, but I promise you, if you draw this like a couple of times and like sit with this, you know, you just had your first GI lecture, this will start making a lot more sense. But that's all I have for you. We are actually able to cover way more than I thought we were going to be able to, which is really awesome.
Thank you.
Does anyone have any last minute questions?
Tyler, regarding that line diagram, do we send you an email address or?
Say that again. I'm sorry.
So in regards to that line diagram that you said you're gonna send us, do we give you our email address or?
Oh, I'll send it to your class reps and they'll send it out to you all.
Oh, awesome. Thank you.
Yeah.
Hi, Tyler. I have a quick question about the muscles on in the abdomen where like they mentioned something about leaflets. Where are those exactly located?
Are you talking about like the what's it called? Like the median, lateral, umbilical, or like I'm not sure what the leaflets are.
So Dr. DeRusso did a thing where he demonstrated like the external obliques and internal obliques.
Oh, sorry, I didn't mean to interrupt you. I know exactly what he's talking about. That's
Okay.
like the at least I think I know what he's talking about. So you know how you have the rectus abdominis muscles, and then there's like the linea alba in the middle. That's like the tendon insertion for all the muscle, like the rectus abdominis muscles in the middle. If I'm remembering correctly, I think the leaflets are like the tendons of the obliques that like kind of cross over and attach on either side of the rectus abdominis muscle.
Will they tag that?
No.
Okay,
No, no.
that's good to know. Thank you so
No,
much.
no, no. The leaflets are just like the layers of the muscle. So like it's kind of similar to like the internal and external intercostals, like with the hands in your pocket thing. Like the external obliques are from lateral to medial. They put your hands in the front pocket. If you pull that leaflet back, you have the internal intercostals that are like medial to lateral, and then the ones that are going transverse are the transverse abdominis. If that makes sense.
Yes, that does clarify. Thank you so much.
And just as a little, I don't know, they pinned the transverse abdominis last year.
Dang, all right. I'll definitely look into that. Thank you.
Sure. Does anyone else have any last minute questions before we log off for the, I think physios after this? I don't know.
I do. I just have another question. Today in class during our interactive session, we had a clicker question about like the boundaries of the inguinal canal, and contrary to the chart that's literally in our lecture slides, Dr. Mormon said that the posterior wall is actually made up of the aponeurosis of the external oblique. Is that
Hmm.
correct?
I based what I just went off with you guys off of, I believe the slides and then some like multiple third party resources I compiled to make that mnemonic malts. So I would go with what Dr. Mormon says because that's likely what they're going to test you on. But with that said, if it's in the slides, like that's, and it's something that says otherwise, and it's in a textbook and it says otherwise, you can argue that on the exam.
Okay, thank you. Because he said that Dr. Rich made these slides, and he said that's something that Dr. Rich tests, but that's not something that the boards would test. So he didn't really like give too much clarity as to what the correct answer actually would be.
I or makes it the floor.
Sorry, you cut out a little bit. What was that?
You said that he said the external oblique makes up the posterior aspect or the floor.
The posterior aspect, because he said it kind of like hooks around.
Yeah, I wish I had an answer for you. I don't know. Now, with that, here, let me share my screen with you really quick, and then we got to log off. I did just find something while we were chatting. Maybe this is what he's referring to. Can you see my screen?
Yeah, I can see it.
Maybe this is what he's talking about. Like it like wraps around. But
Oh.
that's not how we were taught it last year. That's not how I was taught it as a master's student.
Yeah, and that's not what the slides say either, like the chart that's in the slides. So I guess if anything, I'll just go with the slides for exam purposes.
Right. I'm sorry. I wish I had a better answer for you. I literally just looked this up right now, but that's probably what he's referring to. But that's not how we're taught it.
Yeah, thank you though. I appreciate it.
Sure. All right, everyone. Well, we got to log off so physio can start. Thank you all for joining. Hopefully, this was